Hi, everyone. My name is Christine Torjussen. I'm at FHI 360. I'm the project director for MOSAIC, and I'm happy to moderate the webinar today for the Global PrEP Learning Network. This is a quarterly webinar series that we've been running for many years now through various mechanisms, options, choice, MOSAIC, and we're happy to be together again today, thinking about the progress that we've made in oral PrEP delivery and what we really need to do to scale up. We have certainly made some progress, but we still have a ways to go. So very excited today to welcome our speakers and panelists to discuss this issue. Next slide, please. So as noted, we would love for you to introduce yourself in the chat and feel free to add your comments or questions in the chat as we go along. And then we will also have Q&A time and a panelist discussion. Please note that when you do write in the chat, it would be great to make sure you have tagged everyone. I think there's an automatic, the Zoom automatically puts it on hosts and panelists, but that means not everyone can see your question. So if you want everyone to see the question, please put everyone. Next slide, please. So I'm very pleased to introduce our speakers today. Andrew Grulich is the head of HIV epidemiology and HIV prevention and the prevention program at the Kirby Institute at the University of New South Wales in Sydney, Australia. And he sits on the governing council of the International AIDS Society and was principal investigator of the Sydney-based EPIC NSW study of PrEP implementation. So we're thrilled to have Professor Grulich with us today. Heather Marie Schmidt is the regional advisor for PrEP jointly with UNAIDS and with WHO. And in this role, she develops global guidance on PrEP and PEP and provides technical assistance to countries, organizations, and communities, particularly across the Asia-Pacific region to support PrEP programs. And she is passionate about improving community access to and uptake of HIV prevention options. Next slide, please. We also have a number of panelists with us today, some of whom are probably very familiar to you because they've been on our PLN webinars before. Happy to have Daniel Wary back with us. Daniel is a regional technical advisor for JPIGO and leads 2 implementation science projects on pharmacy-based PrEP delivery in Kenya. And he was previously the project director for the Jalindi project that supported the scale-up of oral PrEP in Kenya alongside the Ministry of Health. Cindy Matse is the National PrEP Coordinator at the Eswatini Ministry of Health, and she is responsible for providing technical leadership and coordination, facilitating the development of policies and plans, and designing programs for key populations and PrEP programming in Eswatini. She is a nurse with extensive experience in public health and HIV and holds a bachelor's of nursing degree and a master's in public health. Chris Obermeyer is an advisor at the Global Fund for HIV Prevention Product Introduction. He's worked in public health for over a decade with the aim of increasing access to and uptake of HIV services by those who need them most. He has worked alongside stakeholders on oral PrEP introduction and scale up in a number of settings, including actually on the MOSAIC team most recently, but now he's with Global Fund and he's going to continue to support countries with introduction to new HIV prevention products through his new role at Global Fund. Next slide, please. And Musanda Musanda is with us from Zambia. She is the Community ART Advisor at USAID in Zambia. She's also the PrEP lead, and she supports USAID implementing partners to increase PrEP provision through community and facility-based interventions. She's the activity manager for the Discover Health Project, which until recently led the National PrEP campaign and with a goal of increasing uptake of PrEP services across the country. She also sits on the National PrEP Task Force, which is responsible for developing national guidelines related to PrEP implementation in Zambia. And then our final speaker, I'm not sure is going to be able to join us. She is currently caught up in a meeting with the minister, and so we're not sure she's going to be able to join us, but hopefully she will. Phan Nguyen is the Director General for the Vietnam Administration of HIV/AIDS Control and has been working there for over 27 years. Her expertise includes HIV counseling and testing, laboratory quality management, health system strengthening, HIV surveillance and monitoring, and HIV treatment and care. So with that, we will move on to our agenda. we welcome you all. We've done our introductions, and now we're going to move over to Andrew to talk us through scaling up PrEP to maximize HIV prevention impact. Over to you, Andrew.
Thank you very much for the introduction, Christine. As you just heard, I'm Australian, and I work predominantly in Australia, but also in the Southeast Asian region. I am aware, looking at the list of participants as you've all been joining, that the large majority, I think, online are from African. I think that the learnings in my presentation are universal; they're not country-specific. So I hope you find that to be the case. Next slide, please. So what I was asked to do was just to provide some general framing remarks, a framing presentation to introduce the concept of scaling up PrEP and whether we, well, not whether we've gone far enough, but how much further we need to go and how we might measure how we're moving ahead. And it's based on this recent review that I did with my colleague, Ben Babington. It was published a couple of months ago. Next slide, please. And, it is worth reflecting quickly that it's now more than 10 years since co-formulated TDF-FTC was first approved in one country in the world, in the US, for men who have sex with men. It's 8 years since that recommendation was extended to heterosexual people and injecting drug users, and 7 years since global recommendations recommended that PrEP should be offered as a prevention choice for people at substantial risk. So it's been around really quite a long time now. And, you would have hoped, I would have hoped in that time, we would have seen a pretty large scale up. So next slide, please. You will have seen a slide variant of this many, many times as the PrEP rollout has been moving on. The slight difference in the way we decided to present it in this article is that we did correct it for population size. So this is the PrEP initiation rate per 1,000 people in these around the world. And when you control for population, you do see that now the countries with the highest PrEP penetration globally are in East and Southern Africa. The US is by far the country with the most PrEP initiations, but of course has an enormous population. And once you correct for that, it's now actually having most penetration in Southern and Eastern Africa. Next slide, please. So we did have a target for 2020, which was a UNAIDS target, which was for 3 million people on PrEP, which we missed by about a third. But you can see from this graph, which I think is a WHO figure, that initiations have really accelerated enormously in the last few years. So, if we were having a presentation like this just a few years ago, the situation was not looking great, but particularly the African region in the last couple of years has come roaring ahead. Of course, a slide like this does collapse a lot of data and we can't highlight individual countries, but it's a shame Dr. Huang can't join us tonight because I think Vietnam is standing out as, for example, as somewhere that is really ramping up PrEP very, very quickly now. And there are some real success stories emerging around the world. But by 2021, over 2/3 of initiations were in Africa, and there were about 12 countries with PrEP initiation rates of more than 1 per 1,000 people. Next slide, please. So I want to take a quick reflection on the role of targets. And if we all think back to 2014, when the fast track targets were first introduced for 2020, and remember the introduction of 90-90-90. Old people like me can remember that very easily. And I remember thinking at the time how aspirational those targets were. They seemed as if they would be nearly impossible to reach. And I think they were greeted with some cynicism, at least in some quarters. But I think this is a role of goals and targets. These measurable targets, which are high level and are aspirational, so that they are inspiring. They're not easy to reach. They should not be easy to reach. And they should be based on some evidence. And certainly the 90-90-90 targets were based on mathematical modelling evidence showing that you needed to get at least to those levels of diagnosis, treatment, and undetectability to greatly impact the HIV epidemic. So I just raise this because I don't think we've had such inspiring and high-level targets for PrEP use, and I want us to think about whether that might be a good idea. Next slide, please. So just a little more on the 90-90-90 targets. You will see now when you go to international AIDS conferences, when you talk to donors, when you talk about the performance of countries, there is a lot of focus on these 90-90-90 targets. You know, and you can get them by country, you can get them further broken down by region, and they have been enormously useful. And here's just, you know, one graph. This is the global figures on progress towards 1994, broken down by gender. Next slide. And the other half of the 90-90-90 was that they were introduced not only to improve the health of people living with HIV, which was certainly extremely important part of the reason for doing it, but also to reach transmission. And so we were aiming for a target which was missed in 2020, and the little red dot you see in 2025 shows us just how ambitious that target is. It would take a real bending of that curve if we were to reach that 2025 target, which is why UNAIDS have been talking about this as targets that are in danger of not being met. Next slide, please. So what about PrEP targets? And the paper that my colleague Ben Babington and I wrote really makes the point that, you know, we're really missing these top level PrEP targets. We did have a number, 3 million, and we have a new number of 10 million actually. But the PrEP targets are actually somewhat hidden in this broader concept of combination prevention for all. And so here I've copied these this section on prevention targets from the UNAIDS report. And you can see there's a lot of focus on this target of 95% of people having access to effective combination prevention options, which I think we would all support. It's not that that's a bad thing, but PrEP becomes somewhat hidden within that overarching goal. And then we have PEP, we have circumcision goals, we have condom goals, all of which are important, of course. Next slide. And we have some reporting in that report on progress against targets. So the 2022 report, for example, reports that 24 countries reached the target of 90% coverage of condom use among sex workers. There were 18 countries that reported reaching 90% target for use of sterile needles, but no reporting about meeting targets on percentage of people who might need PrEP who are on it, rather reporting just against the numbers who are currently on PrEP. And there is reporting by, in the top of those two figures, by region. And you can see, again, this enormous increase in Eastern and Southern Africa recently. Western and Central Europe and North America increased earlier, but increasing less now. And just presenting visually how far we have to go if we're to get those 10 million people on PrEP by 2025. Next slide, please. So it is interesting, though, if you go into the depth of the global AIDS strategy, you do find that there are disaggregated PrEP targets. And you have to go to page 132 of this report to find these, but they are there. So when you look here, there are targets for PrEP use by risk category, by very high, or moderate and low. Separately for sex workers, gay men and other men who have sex with men, people who inject drugs, transgender people, prisoners and others in closed settings. So that's for key population, and benchmarks by prioritization stratum here. So the goals are there, and you see, for example, they recommend 50% of gay men at very high risk should be on PrEP, but there's no reporting against these yet, at least at the global level. So next slide. I just wanted to talk about a few settings which have adopted really quite simple, very ambitious, measurable, high-profile PrEP targets as part of their strategies. So in Australia, our current national strategy is approaching its end, and it has a target of 75% of eligible people on PrEP. I'll tell you a bit about how that's measured in a moment. The US National HIV Strategy aims to increase PrEP coverage among people with a PrEP indication, and that's quite tightly defined in the strategy, to 50%. And Vietnam has targeted 30% of gay and bisexual men taking PrEP by 2025. So these are quite measurable targets. Next slide, please. So here's how we measure this in Australia, and these are the data from the state of Australia that I live in, but this is measured around Australia. So our target is this, because our predominant population in Australia is gay and bisexual men, our target is that 75% of gay men who report condomless anal sex should be on PrEP. And you can see between 2015 and 2019, we made terrific progress towards that target. And it was looking like we would break through that target, and then COVID happened. And so we have had a plateau since then. And there's a great deal of debate about how much higher that needs to move. One of the states, the state that I live in, New South Wales, is now going to aim for 90% for this target. And as that PrEP use was ramped up between 25 and 2019, you'll see in the right-hand figure, we saw markedly declining diagnoses in that population. The rates of HIV had declined about 40% even before the COVID epidemic hit, and where, like most of the world, we've had decreases in HIV testing, which make it a bit more harder to interpret these recent trends. Next slide, please. There have been similar findings of declining HIV in other high coverage PrEP settings. So that probably the best known of all of these settings is San Francisco. Being in the US, it did start PrEP use earlier than just about anywhere else in the world. And new HIV diagnoses declined by more than 70% between 2012, when PrEP rollout began, and 2020. The US nationally has not had the same success, but because they're now measuring PrEP uptake, you can then correlate success in declining HIV with increases in PrEP use. So there has been quite a major decline in HIV diagnoses in white gay and bisexual men who have the highest PrEP uptake, and no decline in black gay and bisexual men who have the lowest PrEP uptake. And there is regular reporting in the US on PrEP uptake in these populations. And the United Kingdom certainly has seen a major decrease in HIV diagnosis in the year in which PrEP has been released at all. I should say this is not only PrEP. By no means am I saying this. In all of these places, there's been very large increases in treatment as prevention at the same time. But PrEP has been a critical element. Next slide, please. So how do we get towards increasing PrEP uptake? And we're going to get a great presentation from Heather Marie Schmidt in a minute on this, but these are some of the areas that really are critical. It has been pointed out by many that PrEP is fantastic for reducing HIV risk, but it is also good for taking the anxiety out of sex for people who are scared about HIV transmission. So it's about decreasing risk and increasing pleasure, and therefore improving people's sexual lives. We need to simplify PrEP care, and this is absolutely where the WHO is heading now, to make it easier to get PrEP to the people, and we're going to hear about many of these tonight. It is important that when we're talking about adherence, we need to talk about improving adherence during times when PrEP is needed. We shouldn't expect that people will want to take PrEP for the rest of their lives. they will want to be on PrEP for periods when they need it. And that does lead to complexities with measuring scale up, because it's not simply a matter of more PrEP is always better, because there will be times when people don't want to be on PrEP. We are entering a new era where we are getting new methods of PrEP, which will increase the choice. And very importantly, and we've seen in a number of locations around the world, when we introduce PrEP, we really need to pay heed to equity, because otherwise we will we run the risk of enlarging existing inequalities. Next slide, which I think is my final slide. Yeah, so just to conclude, we are now seeing really rapid increases in PrEP uptake, which is gratifying. It's taken us a long time, but is really happening now. It is really worth remembering that there are now several locations around the world which have demonstrated that high-level targeted PrEP implementation can lead to rapid reductions at the population level in HIV. And I'd be very interested to hear the discussion tonight about whether we're beginning to see signs of that in Africa. We do need innovation to make PrEP easier, and we need innovation in the form of new forms of PrEP. And certainly I think it's absolutely the case that we can't end HIV as a public health threat by 2030 unless we get much higher PrEP use. And the particular argument that we made in this paper is that really having more ambitious, higher level, top level PrEP targets will help in driving these increases. Thank you for that, and I'll hand back to Christine, I think.
Yes, thank you so much, Andrew. That was really terrific. I would welcome folks to write any questions or comments they have in the chat. We have a few moments for Q&A. I do see one comment here from Catherine Kripke, which I will go ahead and read out loud for the group from Avenir Health. She writes, one of the reasons why we can't report against targets for PrEP is that PrEP use does not necessarily need to be continuous. So defining the number of people that need to be on PrEP and then counting the number of people that are on PrEP is not straightforward. We have been counting PrEP initiations, but we have not consistently been counting the total amount of PrEP product distributed. And many settings are not collecting consistent data on who is getting PrEP. Further, it can be challenging to quantify the people in need of PrEP. So comparing PrEP use and uptake versus the size of the population in need to produce a % coverage is not at all straightforward. We recommend collecting data on the amount of PrEP product distributed and where possible who is receiving PrEP, such as key populations, pregnant and breastfeeding women, etc. So I'm just wondering, Andrew, if you would like to reflect on that comment from Catherine.
Yeah, I think Catherine makes a good point. This is not simple and straightforward, but I would also argue that we shouldn't let the good be the enemy of the perfect. Measuring adherence on PrEP is extremely difficult. The way we report against it in Australia is we ask about PrEP use in the last 6 months, and that's not perfect, but we do, in our research studies, pay a lot of attention to ensuring that people understand what PrEP adherence means, about being covered when they need to be covered. I think Catherine's suggestions about total amounts of PrEP is a reasonable one, and coverage in key populations is always going to be important because the people most at risk need to be covered.
Thank you. Carrie Johnson has also made a comment about, given the increasing diversity of PrEP options, such as oral Truvada, on-demand PrEP, CAB-LA, Dapivirine, et cetera, that it's important that we clarify what we are discussing or measuring when we say PrEP. So I don't know that there's much to say about that other than agree heartily.
Yeah.
So really today's webinar is actually focused on oral PrEP, and I can't remember if we had that specifically in the title, but yes. So today we are focusing on oral PrEP because that is what we have in the market, and I think probably most of the data that you shared, Andrew, is more related to daily oral Although actually you probably ED PrEP has not been scaled up broadly, but perhaps in Australia it has.
Yeah, we are seeing quite large increases in ED PrEP over the last couple of years to now about 20% of gay men on PrEP are taking it as event driven, and the COVID epidemic has been a big part of that. That for a lot of men, rest became much more episodic and not continuous, so people didn't want to take it every day. But yes, I think that is increasing in many places around the world. Of course, only when the epidemic is in men who have sex with men, because it's not recommended for women.
And then Chris Obermeyer is one of our panelists, and he has a comment. So I don't know, Chris, I might just turn it over to you to comment on this.
Oh yeah, I just wanted to share this this article that it was published yesterday, so I haven't had the full time to read it, but I thought the audience might be interested because Andrew mentioned, effective uses, people using it during periods when they really need it, and that's going to come and go over time. And so I think this was a further analysis. I think the HPTN 082 study. So feel free to check those results out.
Great, thank you. Then we have a question for you, Andrew, on whether when you talk about increasing pleasure, are you referring to condomless sex?
Not specifically. What I'm talking about is taking the worry about HIV transmission out of sex. And so for certainly in many gay and bisexual men, the spectre, if you like, of HIV transmission in sex has led to a lot of people being anxious about sex. So being fully protected, because you're on a virtually, you're taking a virtually 100% effective preventive intervention, takes the anxiety out of sex. We hear stories about this all the time, and those data have also been reported in relation to heterosexual sex in many settings as well. So it is true that some people may elect to use less condoms, and that does happen in many places, but that's not what I was referring to. It's more the worry about HIV transmission being taken out.
Thank you. Victor asks, what is the implication of condomless anal sex on PrEP on STI control in the Australian setting?
So this is a very a very commonly brought up issue, not only in Australia, but around the world. And we have seen in some settings, at least, decreased condom use follow increased PrEP use. In our setting, quarterly STI testing is part of the PrEP program. And that means that PrEP, any STIs get diagnosed early and treated early. And so we have not seen any further increases in STIs since we started the PrEP program. STIs in general have been increasing in places like Australia, but many other countries as well. But that increase predated the beginning of PrEP programs. And PrEP programs don't seem to have had much of an additional setting effect, but that is in a setting where regular STI testing in asymptomatic people is happening.
Thank you. And I just want to note that Musanda did put a comment in the chat. In the interest of time, I'm actually going to move us forward, but Musanda did put a note in the chat back to Daniel's question on what does it mean to increase pleasure. I believe that was the question about what this is, some research that was done in Musanda around this. And then Carrie also made a further comment, and I think this is, definitely resonates as well, that it is, as we have more and more PrEP options, it is going to become more confusing. And I think one of the issues that is going to become more challenging includes the measurement, as you have talked about, as we talk about reaching these targets. And it's going to be very important that our targets are for PrEP. I think it will be important that our targets are for PrEP as a category, and that it can be disaggregation below that of the different products. But we need to be looking at PrEP coverage that allows for different choices by different individuals for what fits best in their life, and also for the fact that individuals may switch between products. So they may use, one form of PrEP for part of the year and another form of PrEP for another part of the year. I don't know if you want to say anything further on that before we move on. I think we need to move on to our next.
Yeah, I would just agree with you, Christine. I think choice is really important, but a target for an overall prevention target should measure overall PrEP use.
Yeah. So Andrew, I might ask you to see the remaining questions in the chat or comments and respond to those as we go on.
Okay.
And we will turn it over now to Heather Marie Schmidt to talk through the simplified guidance that WHO has provided for oral PrEP delivery. Over to you, Heather Marie.
Thanks, Christine. And I want to say that I'm presenting very much on behalf of the team from WHO, Rachel Bagley, Michelle Rodolph, who led the guidelines on CAB-LA, and particularly Robin Schaefer, who did an amazing job leading the technical brief for differentiated and simplified PrEP. Next slide. So WHO first recommended oral PrEP about a decade ago. And in recent years, you can see from this that oral PrEP has really accelerated to an estimated 1.8 million people in 2021. And this is a doubling compared with the previous year and despite COVID-19 disruptions. As Andrew mentioned, this was largely driven by a substantial scale up in Eastern and Southern Africa and in countries such as South Africa, Kenya, and Zambia. And so despite this, our current trajectory, next slide, means that we need to accelerate PrEP if we have any hope of scaling up PrEP to sufficient levels to end the epidemic by 2030 and to achieve those UNAIDS 2025 targets of 10 million persons of 10 million persons. So to support the scale up, there is an urgent need for additional choices for PrEP products. And we know, previous slide. That there is an urgent need for additional choices in PrEP products. We know that different options work for different people at different points in their lives and with different partners, as well as an urgent need for simplified and differentiated implementation to improve uptake and effective use. And both of these really will work together synergistically to support scale up. Next slide. In July 2022, WHO released a new recommendation for long-acting injectable cabotegravir, and this is the second WHO recommended long-acting injectable PrEP product after the dapivirine vaginal ring. Under this recommendation, long-acting injectable cabotegravir may be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination prevention approaches. And this was a conditional recommendation made on the basis of moderate certainty of evidence. From this evidence, we know that PrEP is highly efficacious, it is often acceptable, and it has a good safety profile. But implementation science is urgently needed to fill evidence gaps to ensure that CAB-LA is used most effectively within a PrEP program and that it's implemented as a priority to support PrEP programs. So this really means prioritizing CAB-LA as an additional option for PrEP delivered alongside oral PrEP and the dapivirine vaginal ring. Next slide. Also in July, WHO released new guidance to support differentiated, simplified, demedicalized, and comprehensive PrEP services. And these are really aimed to make, this guidance is aimed to make services more acceptable and accessible, to support uptake, persistence, and effective use, while maintaining quality and safety of services and supporting the achievement of both country and global goals for PrEP. And while the focus of this guidance is oral PrEP, there is the inclusion of the dapivirine vaginal ring and long-acting injectable cabotegravir as relevant. And so this technical brief, next slide, includes revised guidance on starting, using, and stopping PrEP. Previously, under WHO guidance, event-driven PrEP dosing was only an option for men who have sex with men. Next slide. With the new guidance, there is an expanded eligibility for event-driven dosing, which is for the sexual acquisition of HIV. And this means that all cisgender men And for example, transgender women who are taking gender affirming hormones can start can start PrEP with a double dose 2 to 24 hours before sexual exposure, ideally closer to 24 hours, and continue using 1 dose per day until 2 days after the last potential exposure. And this is the same whether the intention is to use PrEP for a single event, what we would typically call event-driven dosing, or over a longer period of time, which is the equivalent of daily dosing, or something in between those. And importantly, a change is that HPV infection is no longer a contraindication for event-driven, oral event-driven PrEP dosing. For all other groups, and this includes, but is not limited to, cisgender women, to trans men, to trans women who are taking gender affirming hormones, and to people who are using oral PrEP to prevent HIV acquisition from injecting practices. Oral PrEP, daily dosing for oral PrEP is really the option here. And so that hasn't changed in terms of the lead-in time. 1 daily dose for 7 days before exposure, continuing with 1 dose per day. But the time to stop has been reduced to only 7 days. So that means continuing PrEP with 1 dose per day until 7 days after the last potential exposure. Our guidance has also, next slide, been updated around hepatitis B and C virus. Next slide. Now, PrEP services provide a really unique opportunity to both address hepatitis B and C, as well as other multiple public health issues. Next slide. And so hepatitis B and C, under the new guidance for hepatitis B, where indicated test once within 3 months of initiation, once within or at 3 months of initiation. And for hepatitis C virus, similarly, where indicated within a population, somebody who is at risk of HCV infection, to test once within or at 3 months of initiation and every 12 months. Importantly, hepatitis B and C testing should not be a barrier for PrEP services. And as I've already mentioned in the context of hepatitis B, but this is also true for hepatitis C, testing is not a requirement for PrEP use. And that's why it's particularly important as a barrier, that it's not a barrier. There are specific considerations for CAP-LA. Next slide. So now moving on to kidney function monitoring. Very quickly for this one, the simplified guidance is on measuring kidney function is really that it's optional for those without comorbidities who are aged under 30, and depending on the resources, for those aged under 50. Next slide. Those with comorbidities and those aged over 50 years, that kidney function monitoring can be done once within 1 to 3 months after initiation, does not need to be done in that initiation visit. And screening can be performed once every 6 to 12 months, depending on program. Next slide. HIV self-testing for PrEP is something that is, I know, a huge interest to many people implementing PrEP programs and testing programs. HIV testing is perhaps the only test that's absolutely required prior to starting or restarting PrEP. And it should be conducted while taking PrEP, regularly while taking PrEP. HIV self-testing is an additional testing choice that can complement existing HIV testing strategies. It may reduce clinic visits. It may be preferred by clients for convenience, for privacy, for self-managed care. It may increase PrEP use and persistence and testing frequency. It's important where programs do decide to introduce HIV self-testing as part of their testing algorithm for either initiating or continuing PrEP, that there is really importantly clear and concise messaging, and that it forms part of a comprehensive service. So there is still a need for operational research on HIV self-testing, supported PrEP delivery, including understanding and optimizing delivery, understanding the impact as well as costs. But really the upshot of all of this is, yes, the next slide, is that it can really support the delivery of PrEP services. And the final part of, so next slide, the final part of the new guidance, and quite a large section, is around differentiated PrEP service delivery. And differentiated PrEP service delivery can support the scale up, access, acceptability, and effective use of PrEP broadly within a community. Differentiated PrEP services are person and they're community centered. And that means that they're really adapted to needs and preferences of end users, people who would benefit from the use of PrEP and people who are using PrEP. They can support making services more accessible and more acceptable, and therefore may improve uptake, persistence, and effective use. The differentiated service delivery building blocks, which are well known to many on this call, can provide a framework for initiation, follow-up, reinitiation, and switching between products, which is going to be a really important component of PrEP services going forward as more and more programs introduce the defibrillary vaginal ring, as well as long-acting injectable cabotegravir alongside oral PrEP. Next slide. Under the where of the differentiated service delivery building blocks, there are particular considerations, and this is not an exhaustive list, but are things for communities and for programs to consider. And that includes site locations and service types that to ensure that they're designed as person-centered and integrated. Community involvement in all aspects of PrEP delivery, but in particularly where a service is delivered, is really important. Governments also need to support those. And these services need to be supported by appropriate clinical oversight and referral pathways, logistics systems, infrastructure, and integrated data systems. And sorry, next slide. There are many examples of amazing differentiated service delivery systems for PrEP, including mobile PrEP. This is a photo from Vietnam. Telehealth for PrEP, and this is an example from Brazil, and it was something that was introduced quite a lot during COVID, often by necessity, but has proved to be really effective for delivering services. And next, and pharmacy-led PrEP, and this is an example from Kenya. But these are just a small number of examples for differentiated services across the globe, and there are many more. Next slide. Who provides the services is really important. And so looking at task sharing to ensure the efficient use of available human resources, this includes using physicians, nurses, pharmacists, and importantly, community health workers in a way that makes sense and is efficient, but also acceptable. Assessing the acceptability of provider types for different PrEP users, and this will vary often depending on the community needs, and ensuring the registration and regulation for provider types to be able to provide PrEP. And this may vary by product. For example, long-acting injectable cabotegravir is an injection, so accreditation of providers to provide that injection may be required. And in some cases, like pharmacists, there may be a way for pharmacists to be accredited to be able to provide that. In much of Africa, there are amazing nurse-led programs. And that training and accreditation of providers, quality assurance is really important, ensuring that linkage and that services are properly remunerated. Next slide. Next. And finally, the when, so the service frequency, and the what, the service package. As has been mentioned, I think by Andrew, as well as I think Christine mentioned this as well, PrEP use is dynamic. People do not use PrEP according to our published guidelines and protocols. They do not turn up necessarily on the day that their appointment is due. Maybe they do, that's great. But people use PrEP in a lot of different ways, and PrEP use can be really complicated. And so accounting for that dynamic use and accommodating that within a service is really important. And that means really being client-centered and responsive. Follow-up and dispensing can be tailored to the needs of PrEP clients. Some PrEP clients, and this includes some PrEP clients may only be interested in attending a service for PrEP. Others will be really after an integrated service package that is responsive to their needs. And it's important to look at the integration and co-delivery with things like STIs, with family planning, contraceptive services, antenatal services. And this is really, again, I know I've said it a lot, but really about making these services as responsive and as client-centered as possible. And these are really important tools and considerations within a program for differentiated service delivery to support that scale up and that rollout beyond facilities. And we know that if we're restricting PrEP to facilities, there are huge groups of people that are never going to be able to access PrEP. And that is, really not okay. So there are really a lot of options available. Next slide. And that's just a big thank you to everyone who contributed to both the technical brief for simplified and differentiated PrEP and CAB-LA, and some links for further information, and to flag that we'll be doing a two-part webinar specifically on CAB-LA later on.
It was terrific. Thank you so much, Heather Marie. So we welcome questions in the chat for Heather Marie. And I did notice one, but I wondered if, I don't know if you want to answer, if actually Cindy might want to answer, because it's they have a lot of experience on ED PrEP dispensing in Eswatini. But Victor was asking, what has been the experience of dispensing ED PrEP for MSM and eligible transgender people that we can learn, considering that we are in a setting, Africa, where we have a 30-pill bottle for TDF3TC or TDF-FTC?
So I would really welcome Cindy's reflections on this. But from my perspective, what I'd like to say is, with ED PrEP, you cannot guarantee how often somebody is going to need PrEP. So knowing that your first visit, let's assume it's from initiation, your first visit, your initiation visit, and your next visit are going to be 30 days separated. You really want to make sure that any client has sufficient pills to make sure that they could take daily PrEP throughout that period if they need it. What you don't want, what is perhaps the most, would be the most worrying thing from my perspective, is very much a client running out of pills, or wanting or feeling like they have to ration their pills because they don't feel like they have enough to take it in accordance with their exposure. So from my perspective, I wouldn't be restricting somebody who says that they want to take ED PrEP to only 15 pills or whatever that is. Make sure that they're covered to be able to take it for the full period should they choose to. You can reassess this at another visit to see how many they've taken, but always make sure that they have enough to take it daily.
That's a great point, Heather Marie. Cindy, do you want to add anything to that?
Okay, thank you. I think I will concur with what she's just shared. That's what we have done as a country. We are dispensing the whole bottle with the 30 pills when we're initiating this target population. so that we allow them in case they will switching from being an event exposure to a daily. So we always provide the one. And what we have seen is that they don't even come back based on the appointment schedule. So it is best to provide them with adequate so that they can be switching from being an event to the daily. And we follow them up within that first month so that we can see if they are still continuing with their drugs, because really it is a challenge for them to come back and for those appointments where we expect them to come, whether it's the first visit or after the 3 months. So it is very important to give them as we are giving, and the visits are based on what we are doing for the daily oral PrEP. We haven't changed that so that we align that one. Thank you.
So Cindy, are you saying you will dispense basically 90 pills for a 3-month supply, even though may then last them for 6 months or 12 months?
Okay, for the first visit, we are giving the whole bottle. That is, we expect them to come at 1 month. But then when they come for the second visit, we consider how much drugs they've used, how much they still have, and then we dispense based on that one. But their visits are still allocated based on the visits that we're using for the daily PrEP.
Okay, that's very helpful. Yeah. Thank you, Cindy.
Okay, thank you.
So we have a comment in the chat from Patricia that one issue that is coming up from the blantyre prevention strategy in Malawi from a human-centered design perspective, and that affects PrEP uptake, is that some clients are linking the drug as ARVs due to branding issues, since PrEP looks exactly like ARVs. This is resulting in associating those taking PrEP as HIV positive and on ARV, especially among female sex workers. Are other countries experiencing similar issues? I can say absolutely yes. This has been a major stigmatizing issue with the oral PrEP pills. I don't know if others on the team want to comment on this.
I can just say that I've had many reports, particularly recently, about this as well. So I think it's something that we need to be a bit more creative with and finding a solution.
Speaking of creativity, go
ahead, Chris.
Yeah, I think Cindy might actually also be able to speak to this, because I don't know if it's being implemented yet, but I know there's been some discussions around how to get around this issue. Maybe Cindy, you can share.
Okay, thank you. To try and address the issue of stigma around the use of the rattling of the bottle and also using the same bottle as the one that is being used for those that are living with HIV, we've tried to develop some labels, which we haven't done it at a national scale, but it's something that we started with the key population, and we have seen that it is addressing the issue. Where we have the stickers or the labels that they can use around the original bottle for those that are not comfortable with the original bottle. And we are also having some dispensing bottles which they can use, because they're also complaining of the rattling of the pills in the original bottle. So we have procured some bottles that they can still empty the drugs into those dispensing bottles so that they can take, we have those that can take fewer drugs for 7 days. We have those that can take the full 30 drugs so that they can address the issues that they are faced with. So what we have seen, it is really important that we try and address the issues that they're raising to improve the uptake and the continuation use of PrEP. So those are the things that we have tried to implement. But we are yet to see, since we have just started to implement some of these strategies, the labels and the dispensing bottles for the different amount of drugs. Thank you.
Thank you, Cindy. I think in the interest of time, we can do one more question and then we'll answer the rest in the chat. So Chris Okolo has asked, with regard to HIV self-testing, are we saying it could be used in place of the traditional testing for both initiation and refill? Or are we leaving this to the various ministries of health to decide? We are receiving questions from the field about this and need to be very clear.
So like all WHO guidance, it is always up to a ministry to decide. However, what I will say is that our guidance on HIV self-testing is guidance. It is not a recommendation. WHO will be going through a process next year to look at whether a formal recommendation will be made on HIV self-testing on the basis of evidence for PrEP. At the moment, it could be used in place of within the national testing algorithm, but that is a decision for ministries to make within their guidance.
Wonderful. Thank you so much, Heather Marie. We're going to move into our moderated panel discussion now because there's a lot of experience with PrEP delivery that can be shared by our panelists. So just a reminder that our panelists include, do we have a next slide? There we go. It includes Daniel, Cindy, Musanda, Chris, and then Fan is not able to join us because she's caught up in a meeting with the minister. We're going to go on to the next slide with our questions for our panelists. So we're asking our panelists to reflect on these 5 questions. I'm not necessarily asking them to answer each question, but I'm going to read these questions and then turn to the panelists to share some of their thoughts. So the first is, what will it take to effectively scale up access to existing and emerging PrEP products? The second is, what do we have to do in PrEP pilots to lay the groundwork for effective scale-up? What is preventing scale-up from happening? What is required to transition from PrEP demonstration projects or early introduction efforts to integration in a comprehensive national response? And where are we trying to go with PrEP scale-up? What does the end game look like? So that's a lot to reflect on. I'm going to turn it over first to Daniel Wary to share some of his thoughts on these questions. Daniel, over to you.
Yeah, so thanks, Christine. And probably I just want to spend time first reflecting on the first question. And I know some of these reflections will cut across, but I think also just listening to the previous presentations and I think just reflecting deeply around that. I think one of my key takeaways from working around PrEP scale up over the last 6 years or so is that what we programmatically consider as imperfect use to many of the PrEP users actually is perfect use, in the sense that people actually use PrEP in ways that they think suits them, much as that may not be aligned to what is spelled out in the guidelines. And at the same time, I think one key point also just for reflection is if I look at the number of new HIV infections that we are reporting annually, vis-a-vis the number of people who are actually using PrEP, leaves a lot to be desired or to be questioned, that really we have more new infections than the number of people who are actually using PrEP. So certainly I think it points up to this huge gap, and really there's a lot more that needs to be done. So quickly in terms of my reflections, I want to look at 3 key issues around what we really need to do to be able to scale up access. And I think for me, one is really the need to fast track simplification of PrEP delivery, particularly at the policy level. And I just want to take a practical example like event-driven PrEP. Despite the fact that we had the WHO guidance coming out almost 2-3 years ago, it's really taken quite long for a number of countries to translate that into national policy. This is notwithstanding the fact that when you look at program data, a good example, when we looked at program data in Jilinde, what we did see is that the patterns of use, particularly among MSM, were suggestive that many were using daily oral PrEP as event-driven PrEP, much as national guidance was not supportive of event-driven PrEP. So that for me is really a practical example of why we need to really fast track revision of national guidance to accommodate some of the new regimens, as well as including new service delivery models. and also just the need to also simplify and remove unnecessary screening requirements. And I know Kenya has a more liberal national guidance, but thinking across the region and looking at a number of other countries, we have seen this a lot of barriers actually being introduced in terms of policy in relation to screening. The second thing that I wanted also to reflect about is around service delivery models and approaches. And I think the current scale up did leverage a lot on existing platforms. And most of these were particularly platforms that were used for the delivery of HIV care and treatment. And while this may have worked well for some of the populations like serodiscordant couples, it has not necessarily worked well for many other populations. And I think that approach has been more convenient to the health system as opposed to being more convenient to users. And really appreciating the efforts by WHO around the launch of the guidelines on simplified PrEP delivery. So what I think needs to work more, one, I think we need to advance more around integration. What we have really seen is particularly integration between PrEP and family planning, but also cross-platform integration with other thematic health areas. Of important note is from data we have analyzed, we see that many PrEP users have a lot of unmet family planning needs. So they need really to and push a lot more of integration, which could enhance increased access. Then I think the whole idea about community models, which the earlier speakers have really talked about that. From some of the work that we are doing now in Kenya, we are seeing, for example, pharmacy-based delivery models are reaching out to more male clients who traditionally are not coming up for PrEP services through the public facilities. But also most important beyond just pharmacy delivery models, being able to advance more around other community delivery models. For instance, for adolescent girls and young women, we have seen that most of them are reached more through community delivery models. So I think for me, it's important to invest more in understanding the users, understanding which service delivery models will work best for those users, and being bold enough to invest in those models. Because also there's been a reluctance to invest in some of these models, which are considered expensive, but ideally to reach populations such as AGYW, really we need to think outside the box and invest in that direction. And then finally, I think in terms of service delivery, just thinking about investing more in having a critical mass of trained providers, but also being able to invest more in supporting providers as they navigate this balance between the moral and the professional ethos, because provider bias has really emerged to be a key challenge, which really needs to be addressed. And then finally, just thinking around demand creation. And I think this is one area where there's really been a lot of underinvestment in demand creation. PrEP really is not normalized. An evaluation we did in Kenya last year just showed that overall awareness in the country is about 34% in the general population. So it is challenging really for us to expect better uptake if even awareness of some of these products is that low. So I think greater investment in demand creation just to make sure there is better awareness, but also norming. And I think the importance also of norming, and this is what we have seen even as we've been promoting PrEP among adolescent girls and young women, is that while most of them have the intention to use PrEP, if they do consider that the context where they live is not supportive of their PrEP use decision, then most of them will not use PrEP, or if they did initiate, they'll actually discontinue. But where we have invested in building that enabling environment, it has really been supportive of uptake. So I think as we think about scale up, having that enabling environment, and that can only be achieved through norming, which is through sustained awareness and demand creation, is quite critical. And I think finally, it's just around how do we improve our demand creation, both in terms of better messaging, in terms of better positioning for PrEP. I've seen a lot of programs have really invested in approaches such as human-centered design, to really understand and design with the users and just make sure that ultimately the strategies and messages are more resonant with the end user. So I'll stop there for now.
Thank you so much, Daniel. I'm going to turn it over now to Cindy Matse from Eswatini, Ministry of Health.
Okay, thank you very much. I think I will respond based on our experience as a country as we have scaled up the oral PrEP. First of all, I will say it is important to conduct the demonstration projects so that we can collect data and also through some lessons learned that can inform the policymakers, also to involve the civil society so that they can gain confidence in the interventions that you're about to introduce. So this is very important whenever we are introducing this product, the PrEP products. Also, it is important for the government to commit, and also in terms of the funding and also the donors that can support the intervention so that we make sure that we don't experience interrupted supplies of the product, and also to ensure that it is the intervention implementation, it is sustainable. I think it has already been touched, the use of the differentiated service delivery models, both considering the community and the facilities to improve the access to the product, and to be also as Ministry of Health or as programs to explore new DSD models that have worked in other countries so that we can improve the access of that intervention. The demand creation, I would like to emphasize, it is very important that we also have a demand creation strategy that will help to harmonize the messages on PrEP and the programs to be able to deal with any myths, to dispel any myths that might be circulating in the community, because it impacts negatively to the uptake and the continuation use of PrEP. I think I've already highlighted in one of the responses that it is important to also pick the concerns that are coming from our end users and come up with some strategies to address the issues, especially the issue of stigma around the PrEP use being the ARV. So it is very important that we sit down as countries and come up with some strategies that can address this, since it is impacting negatively to the uptake and the continuation use. And then in regards to what to do in PrEP pilots, from what we have seen is that it's important for Ministry of Health to be at the forefront from the inception when you are planning to do those demonstration projects, and be the Ministry of Health to be the one that is driving and coordinating the implementation so that it is easy to align this or integrate the new intervention into the existing services or into the systems, the national systems that are there in the country. And when we are conducting these demonstration projects, to be implemented in the real world settings without interfering or with limited interference, so that, and in all settings that will be considered as we continue with the implementation. So this will assist us to enhance the data collection, the documentation of lessons learned, the best practices and challenges that will help us to then engage the different stakeholders at the end of such, and that will inform the scale up plan. For the preventing of scale up from happening, I think the uncertainties for future funding and sustainability, and also where it's a new product, where you lack data to inform or to convince the policymakers or the civil society for you to introduce that intervention. Those are the issues that usually are a problem. So I will emphasize that the involvement of Ministry of Health from the beginning, it is really helpful, and the commitment. So where are we trying to go with the PrEP scale up? What does the end game look like? I think we are at the stage where we will, as under prevention, will expand our choices for prevention, especially within PrEP. That means that we'll have multiple products available for our end users, which is really exciting. And for our end users, they'll be able to take control of their own health as we're empowering them ever since we started the implementation of the oral PrEP. And then as we expand the choices and also dealing with all the issues that they've already highlighted, I think they will be empowered to also take control of their own health. And for PrEP to be normalized, no longer something that can be hidden, but something that to be proud of. And at population level, we're seeing the decrease in the new HIV infections as we expand the choices, as we sensitize people about all the prevention package that is available for them. Thank you. I think I will stop here. Thank you.
Thank you so much, Cindy. And for those who didn't quite track, we're very fortunate to have these multiple perspectives, because Daniel gives an implementer perspective, Cindy is giving us a Ministry of Health perspective. Now we're going to go to Musanda, who will give us a donor perspective from USAID, and then we'll hear from a global body perspective from Chris. So over to you, Musanda.
Thank you, Christine. So for just mindful of the time, so I'll just touch on a few points. I think what enabled that transition for Zambia from a demonstration project to integration within a comprehensive national response was really a strong enabling environment. As Cindy has emphasized, in Zambia, we didn't just involve the Ministry of Health. Our implementation was really led by the Ministry of Health. The Ministry of Health brought all the stakeholders together, a team consisting of civil society organizations, which included key population organizations, AGYWs, donors, and implementing partners at that time who were going to run the demonstration projects, and really using the lessons learned from those to scale up quickly. The Ministry of Health was eager and really just raring to go and using lessons learned to increase sites that were providing PrEP. And we went from something like 4 in the first year to 100 in the next year. We have now over 1,000 sites in the country that are providing PrEP. So this was really critical to this success in Zambia. I'll also echo a strong social behavior change component. We have a national campaign in Zambia called Zambia Ending AIDS that looked at previous demand generation and realized that it was really outdated and focusing on fear. And as Andrew mentioned, we need to recognize that people enjoy having sex, and how do you address that, but still allow people, ensure that people are self-internalizing risk if they are engaging in risky behavior, and take the necessary steps to protect themselves. So everyone can go on Facebook, look up Zambia Ending AIDS. It engages, young people, especially with sometimes, controversial subjects, but I think that's what we need to do at this point. There's also a healthcare worker app. Somebody mentioned provider-related stigma. And so this allows healthcare workers to download the app and engage in, sort of build their own capacity and ensure that they are addressing some of the stigma that they may hold. And also using lessons learned to really tailor services. So we saw that for adolescent girls and young women, we needed to provide services outside of the facility because we know that they're not necessarily comfortable coming into the clinic. So this is done in Zambia with the layering of PrEP and Dream Centers, as well as just other community-based intervention of PrEP for AGYWs as well as for key populations. So what is our end game? I think as Cindy has mentioned, we need to have an environment where people can cycle on and off of PrEP as required. I'm on risk, I'm at risk right now. I'll take PrEP for 3 months if I have to. I will no longer be at risk and I can stop. And this ability to cycle on and off with the reduced stigma where people are open about PrEP, and whether it's oral PrEP and eventually, CAB-LA, and I can openly seek PrEP as a service, stay on PrEP if I need to, and come off when I'm no longer at risk, and not having to worry about, what people are going to say, the stigma that's going to be associated with that. So I think that is key for us to get PrEP to a point where anyone who is at risk is accessing it and really averting new infections. So I'll stop here. Thanks. Thanks
so much, Musanda, for sharing the great example of how PrEP has rolled out in Zambia. We're gonna turn now to Chris Obermeyer, who's with the Global Fund.
Thanks. I think my colleagues have said a lot of the major points, and I'll just kind of highlight a couple of them and maybe give some examples. I think one of the things that's preventing scale up of oral PrEP, or our current products available in many countries, is quick adoption of WHO recommendation and guidance. In settings like Eswatini, where the ministry has been super supportive and super forward thinking and forward looking in adopting much of the guidance from WHO, we've seen huge impacts on the amount of people that they can reach, and just really impressive work happening there, as well as in Liberia, where Liberia has recently introduced oral PrEP, but has seen huge results because they adopted very quickly the new guidance that was coming out as it was coming out. So I think part of it is that as our evidence about oral PrEP and the recommendations and guidance begin to shift, our systems need to be flexible so that we can more quickly meet clients where they are. Most of the clients and most of the individuals we're trying to reach with PrEP programming are people who we know do not necessarily want to always access healthcare through healthcare facilities. And yet, early on in oral PrEP in many settings and still today, that's the primary place where oral PrEP is available. And we expect that somehow it's going to draw people in. So the guidance from WHO that was released at the AIDS conference this summer is super welcome and really exciting, and creates a lot of opportunity to stop providing PrEP in places where people maybe are fearful to go, and bring it to people within their communities. Alongside this, I think a great part of a lot of the DSD guidance coming from WHO is that it's going to it can make oral PrEP cheaper. That allows countries which is pretty much everywhere in the world, where there are funding limitations, restrictions, to be able to reach more people with the current budget, and then also creates opportunities for introducing new products. As someone who is within a funding organization within the Global Fund, the Global Fund, PEPFAR, national governments, we all have to do better and commit to increasing the amount of funds available for HIV prevention, including PrEP. And we have, in order to do that, we really need countries to be thinking through how many people within the populations that we're trying to reach might benefit from PrEP. And just coming from Zambia a little bit over about a week ago, where there were 2 back-to-back sessions of people learning about how to actually figure out how many people in my country need PrEP. That's a great starting point, because I think, as Andrew pointed out, we don't exactly know how many people could really benefit from this intervention that could be life-changing. So I think those are kind of the 2 main points: is it's quick adoption of WHO guidance and recommendations, not waiting 2 more years until there's another planned opportunity, make an addendum. That's what we're seeing a number of countries doing, and it's exciting. And also there needs to be more commitment to funding these programs, both domestically and from donors. Yeah, so maybe I'll pause there.
That's a great summary, Chris. Thank you. Thank you to all of our panelists. I'm wondering if our speakers, Andrew and Heather Marie, if you have any further reflections you would like to share related to these questions or what our panelists have shared.
I can start. I mean, I commend all of our panelists, because everybody, I think we're all speaking from the same perspective, in terms of that it's really necessary to diversify where we're providing PrEP, to make it easier for programs and clinicians to provide it. There are still a lot of challenges that we need to overcome. And quick adoption of the WHO guidance is definitely going to help us with that. So really encouraging countries, but really, I think also encouraging communities that are at the center of all of this, and the people who would benefit from PrEP are at the center of this. So I think, it's really important that programs are listening to what people want, and what will make it easier for people to make the best choice for their own HIV prevention. And I know that we talk about this a lot, but we don't always operationalize it as well as we could. So challenge to programs to really continue your conversations and your involvement with communities of people who would benefit from PrEP from inception all the way through service delivery and evaluation.
Thank you.
If I can piggyback on what Heather Marie just said, because I think it's super important, and operationalizing it is sometimes more difficult. I was recently talking with someone who was responsible for overseeing some PrEP programming in a country, and I talked about my own PrEP use, and they said, "Wow, I've never met a PrEP user. Tell me about that." And I think that speaks volumes. People, like if you're in a situation where you're making decisions about whether people can or can't use PrEP, or how to scale it up, or where to introduce it, but you've never met a PrEP user, get out there, start meeting PrEP users. You're not going to get it from a short report on community-led monitoring. You need to get out there and meet people who you're trying to reach with the programs. So that's a quick challenge to colleagues on the call. If you've never met a PrEP user, if you've never met PrEP people from the key populations in which in the country that you're in, get out there and meet people, hear about their experiences, understand why they're not using PrEP, why they're using PrEP, how difficult was it to start and restart. So that would be my challenge to everyone.
And can we just say that's a really great way also to start the process of overcoming stigma and discrimination. It's a lot easier to stigmatize and discriminate against groups of people that you don't know. So like this is a way to start really overcoming it, to have that, that dialogue and genuine interaction.
Absolutely. Over to you, Andrew.
Oh, look, I don't have a lot to add beyond to say, I've been really impressed with the enthusiasm and the multiple ways people are trying to get to the same goal, which is that everybody who could benefit from PrEP should be able to get PrEP and should be on PrEP. And there are so many different ways that overarching goal can be made, but within this framework of simplified models of care, I think one thing that we all have to realize, and in Australia and in high-income countries as much as anywhere else, is that most of these people who would benefit from PrEP are young and fit and well, and we shouldn't be making them go to the doctors all the time to get this simple intervention. And so the new guidance on simplification and on community-led programs is a really great step forward, I think.
Thank you so much, Andrew. And I think we have, we have a new challenge coming on. So we have the existing challenge of our existing oral PrEP program and platform that we want to simplify and diversify and expand and scale. And then into this, we have new products coming that have a lot of unknowns of how they will be used and what are some of the parameters that are needed to support their use. So it's going to be an interesting challenge over the next few years to do both simultaneously, right? So to integrate those new products, learn about those new products, and at the same time continue to push for this simplification and diversification. So I just want to, on that note, I'll close us out. I think we have a few more slides, just a little bit of making sure everybody has access to resources. I want to really thank our speakers, Andrew and Heather Marie, and our panelists, Chris and Musanda and Cindy and Daniel. Thank you so much for joining us today. This webinar has been recorded. It is accessible on PrEP Watch. It will be. Give us a week to get it up there. The slides will also be available there. And then I think there's another slide, Casey. Okay, just a note that these sessions are taking place quarterly, and we will have our next webinar in December of 2022. Chris has put his email in the chat. If you want to reach out to any of our speakers, you can reach out to Casey or me, and we can put you in touch as well. So thank you all, and wishing you a terrific day. Take care. Bye now.